I'm going to give you the instructions for this test. I'll introduce each part of the test and give you time to read the question. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll hear each extract once only. Remember, while you're listening, write your answers on the question paper. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now turn over and look at the notes for extract 1.
You hear an optometrist talking to a patient called Marsha Samarina. For questions 13 to 24, complete the notes with a word or short phrase.
Now, Jane, just before we begin, can I start by asking you your age?
I'm 25.
Okay. And what brings you in today, Jane? What's the problem?
Well, I've been feeling a bit tired for the past few weeks, and I don't seem to have much energy to do anything, really. And I was wondering if you could tell me what's wrong with me.
Okay. Well, tell me a little bit more about it.
Well, I started to get tired about 4 weeks ago, and it's really persisted since that time. And I've actually had to stop playing netball because I've been so tired. When it started off, I had some aches and pains in my muscles, and but they seem to have settled down now, and it's really just the tiredness that's persisting. And I've got exams in a few weeks, and I'm really worried that I won't be able to study properly because I'm feeling so tired.
I see. Goodness, that must be very distressing for you.
Yeah, it's really worrying me.
Yeah. What are you studying?
I'm a social work student.
I see. Well, tell me, apart from the aches and pains that you noticed initially with this illness, was there anything else in particular that you'd noticed?
It sort of started quite suddenly, really, and when it started, I had a bit of a cold, a bit of a blocked up head and a runny nose. And I actually went to the doctor at Student Health at the university, and he said I just had a virus and I didn't need any treatment and it would go away. And he didn't do anything else than that, really.
Right, okay. So at the moment, just to let me clarify again, the main problem now is tiredness. All of the other symptoms have settled down.
Yeah, just really tired, and I can't do anything, really.
Right, okay. Well, just before I actually start examining you, can I ask you a few just general questions before we get started, okay?
Mm-hmm.
What's your appetite and weight been like?
My appetite's been fine. I've been eating the same amount, and my weight's steady.
Okay, and have you been running any fevers recently?
No. 4 weeks ago when I had a bit of a cold, I thought I had a bit of a temperature then, but nothing now.
Okay. And your bowel habits?
I've been regular.
Regular, that's good. All right, well look, I think at this stage I'd like to have a bit of a look at you, and we'll talk about things after that, okay?
All right.
All right. Right, Jane. Having had a look at you, I think really the major things that are noticeable are that you've got some scattered glands around your body, okay, those lumps that I felt in the neck, armpits and down in the groin regions, and you may have also noticed a bit of discomfort up in the left side of your abdomen high up when I was feeling. And that is the site of an organ called the spleen, which is also a type of gland which is also enlarged, okay?
So what does that mean?
I think all of these really point to some form of viral illness, quite possibly glandular fever.
Okay. I was just going to ask as well, are you absolutely sure it's glandular fever?
It's highly suggestive, okay. I can't be totally certain at this stage without really doing some tests to confirm it, and I think that would be a good idea to do.
What sort of tests are they?
It's a blood test, and it will involve a small sample of blood being taken. Really, what I'll do is do a specific test for glandular fever as well as looking at your blood in general to make sure that there are no other possible problems there.
And that can tell for sure if it's glandular fever?
Yes, that's correct.
Right. And when you do the blood test, can you see if I'm anemic as well?
Yes, certainly. Is that a particular concern of yours?
Yeah, well, I've been having all those ads on the TV, you know, about if you don't eat enough meat, then you might be anemic, especially if you're tired. And I was wondering if that was my problem as well.
Okay, I mean, tiredness certainly can be one of the symptoms of anemia, and I think it's justified that you're concerned about it, particularly given the publicity that we've been having, but I can fairly confidently reassure you just on having examined you that that would be very unlikely in your case, okay? But we can certainly run that test, and in fact I was going to run that test as a routine anyway.
Oh, that's good.
Right. What you need to do really at this stage is rest, okay? There are no specific remedies that I can give you for this illness. We can't cure it. Your own body will cure it by fighting it off, but that will take a bit of time. How long exactly? Again, I can't be certain. Hopefully within the next week or two you'll be feeling a lot better, but that's something that we're going to have to keep an eye on. At home, really, you need to keep up your diet and keep up your fluid intake, and really we're going to have to organise to meet again and just make sure that this is slowly settling with time.
So, Anita, what has brought you to counselling?
So, I've been in a relationship with somebody for about 6 months.
Okay.
I wanted us to move forward with our relationship and, get married, and he's not on the same page as me, and it's causing a lot of tension. And then in addition to that, my mother's very unwell, so I have a lot of things to deal with at home with her as well, and then my boss is putting a lot of pressure on me to deliver everything on time, and so I'm just having some trouble juggling everything at the moment.
Yeah. And I can see that all of these combined are making you feel quite overwhelmed.
Oh, very. And it's just really, there are some times when I just come home and I have to deal with my mother, and I have to deal with my relationship, and then I have to go to work the next day, and I'm having trouble with that, and it just makes me really upset.
Okay, yeah. And I'm wondering, Anita, how long have you been dealing with all of these issues?
It's probably ramped up in the last 3 months, but I've been in my relationship for 6 months. My mum's been sick for the last 3-4 months, so it's not that new, but it's now starting to get worse. So
yeah. So how have you been coping so far with all of these pressures?
Not very well, but yeah, I just take it day by day. And communication's a bit of a difficult one. Like I said, this is my first time doing counselling, and don't really have anyone else I can turn to. So it's very hard.
Yeah. I do understand that it is very hard to seek support in such personal issues, but that's what we're here for, and that's what we're hoping that we can do with this session as well. So, given that this session's very different to the other ones, I just wanted to know, you told me that you are experiencing some concerns with your partner because you want to move forward and he's not in the same place as you, and your mother's quite sick, and you're looking after her as well, so that's an area of concern for you. And then you have some pressures with work. So I'm just wondering if we could prioritise any of those concerns. What would the biggest concern be?
Well, probably dealing with my mother and my relationship are probably quite equal, because my mother's also putting a lot of pressure on me to get married. Obviously she's not well, so she wants to see her family happy. Dealing with that situation is probably the number one thing for me at the moment, and the work thing I can deal with because I try not to bring work home, but obviously that's a bit hard too.
So when you say dealing with that concern, do you mean working the relationship with your mother or the relationship with your partner?
Probably with my partner first, because I feel like I'm putting a lot of pressure on him because of what's happening with my mother.
Okay, so what we can do is, if it's okay with you, focus on that area first, and we will look at all the areas that are overwhelming you, but we can start by working on that issue first, if that's okay. Excellent. So we only have a couple more minutes before the session ends, and I was wondering if you had any other questions before we go and sign the contract.
No, just maybe in terms of the number of counselling sessions I'll need. I know you said that the first 6 are free, but obviously money is a bit of a factor as well. So what happens if I have to go over the 6 sessions?
And I do apologise, I said when we'll go and sign the contract, but you already signed it. But so if you go over the 6 sessions, it will be $70 after for each session. And you can, like I said, you can continue as long as you need to. So it's really difficult to find a time for every single person and have a set time. So we like to see how it goes, and together we can work out what the best time frame is for yourself. Okay, excellent. So if you don't have any other questions, we can book another time in next week for you.
Definitely. Thanks. Do I speak to reception about that?
Well, I'll come out with you and we can sort that out.
Great, thank you.
Okay, it was lovely meeting you,
nice
and
meeting
thank you
you
so
too.
much for opening up and having that chat with me. And we'll focus on the first topic of you and your partner.
Okay, thank you.
Okay,
Thanks very much.
Thank you.
Part B, questions 25 to 30. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. Now look at question 25. Now, read the question.
The new draft recommendations make 3 points. The first point is that WHO recommends a reduced intake of free sugars throughout the life course. The second recommendation is that the intake of free sugars in both adults and children should not exceed 10% of total energy intake. But we also make a third recommendation, and that is that a further reduction to less than 5% of total energy gives additional health benefits. We know that dietary risk factors are very important factors for the risk of non-communicable disease. We have an epidemic of non-communicable diseases. We have at the moment 36 million people dying from non-communicable diseases, most of them in the developing world, 80%. We have a projection of 50 million for 2030, so it's huge. And dietary risk factors, as well as tobacco, are one of the main determinants of those diseases. I mean, if you remove the risk factors, then a lot of those deaths can be preventable.
Question 26. Now, read the question.
Overall, what we found were some very reassuring things for physicians caring for women with epilepsy and for women with epilepsy who are planning to become pregnant. Because what we found is counter to previous dogma, I think, women with epilepsy are not at a substantially increased risk of having to have a C-section during their delivery, late pregnancy bleeding, or premature contractions or delivery. Also, the findings strongly support that if a woman is seizure-free for a period of time, 9 months to 1 year, prior to becoming pregnant, it's very likely that she will continue to remain seizure-free throughout the pregnancy. So this is very reassuring information to women and their physicians as they plan going ahead with pregnancy.
Question 27. Now read the question.
Opioids like codeine have very limited evidence in the management of chronic persistent pain. I think our role in the pharmacy is to have the conversation with patients to help them understand the biopsychosocial model of chronic pain and to shift their expectations towards improving their function rather than expecting a cure of their pain. We also need to refer these patients to a GP for a comprehensive assessment.
Annoyed customer. This will take more time out of our busy schedules and more money out of our pockets on pain relief thanks to those who abuse it.
It's important to help consumers understand that codeine is a highly addictive drug. We know that tolerance, dependence and addiction to codeine can develop very quickly, and that many people are self-diagnosing and self-treating with codeine combination products available over the counter. I think it's important that we can reassure patients that there are alternatives available in the pharmacy and that if they do need codeine-containing products, that they can still get them on prescription from their GP.
Question 28. Now read the question.
The aged care channel for me takes a lot of the pressure off having to research, find out information. The staff are accepting of it, so it's just another tool, another resource that we use very often, and I'd have to say they embrace it because it's something they can go and do on their own, but it's also something we can do as a group. The aged care channel is pivotal in our training and development resources. It's something that we use all the time. It's part of induction, it's part of ongoing education, it helps registered nurses with their ongoing professional learning. We couldn't do without it. The aged care channel is a great part of our training and development resource. It's the biggest part. We certainly have libraries, lending libraries in each facility. As I said, it's part of the induction progress, so it's pivotal. We couldn't do without it. The channel to me is a different tool. We don't have the equipment or the skills to make DVDs or live television, so it brings another type of learning, because everyone learns differently, right into rooms right across the villages. So for us it's a different method, and a lot of the staff really respond to that rather than someone just talking at them. So the interaction, the acting, the scenario all adds to the learning.
Question 29. Now read the question.
The idea here is to take those cells out of her body or patients' bodies and reprogram them. That's the term for gene editing. Reprogram those cells to identify cancer, put them back into the body in much larger quantities so that the army has expanded, and then see if that can fight the cancer. It's been an early story over the last couple of years, but the early results are quite promising in leukemia and lymphoma. We've seen a couple of years ago in melanoma, and studies are now getting started in other cancers like ovarian cancer, breast cancer, pancreatic cancer. Very exciting story. We, at our center in Nashville, just 6 days ago, opened a trial in the community for patients with lymphoma. So very exciting time. Well, we've always known that there's a genetic link to a number of cancers. The big struggle is identifying whether a particular genetic abnormality in an individual, say at an early point in their life, is going to lead to the development of cancer. So we know for several cancers there's a high risk with certain genes. I guess the one that has caught a lot of attention over the last several years has been what's called the BRCA or BRCA genetic alterations that lead to an increased risk for breast cancer and ovarian cancer. So understanding more correlations like that, if you have this genetic abnormality at birth or later in life, is that going to lead to the development of cancer? A lot of work still in that area. We're learning it's a combination of those genetic risks and probably environmental risks as well. So it may not just be one thing that leads to the development of cancer for the majority of people.
Question 30. Now read the question.
Alright, so Mrs. Smith is a 68-year-old lady. She was admitted 3 days ago with an exacerbation of the COPD. She had a 4-day history of increasing shortness of breath on exertion, not relieved by her puffers. She has no comorbidities and no infection control precautions. She stopped smoking after her first admission about 2 years ago, and she lives at home alone with support from her daughter. She's on IV antibiotics, bronchodilators and steroids, and she's on 2 litres of oxygen via the nasal prongs. She has autocrawling criteria for oxygen saturations. The target range is 88 to 92% because she retains CO2. Mrs. Smith's other vital signs are between the flags, and she needs QID obs and had some spirometry done yesterday, which the team are going to review today. She reports having a fall at home about a month ago, but she's otherwise independent with her ADLs. Falls risk was low, but I used the override option to make her a high falls risk because of her recent falls history. She's been assessed by the physio, and she's on a rollator frame for it to ambulate. Waterloo score is 10 and her skin integrity is intact, and she's responded well to all treatment and she's on a normal diet.
That is the end of Part B. Now, turn over and look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the lecture given by a physician on colectomy surgery. You have 90 seconds to read questions 31 to 36.
Hello, doctor. Please explain to me different types of colectomy surgery.
Well, the surgery to part of or all the colon or the large intestine is called a colectomy, and there are many types of colectomy surgeries. The type of surgery and how much the colon is removed based on the disease and the extent of damage to the large intestine. In the proctocolectomy, the colon is removed along with the rectum. The term procto refers to rectum. With both the colon and the rectum removed, the body will need a new way to dispose of stool. For most people with inflammatory bowel disease, either ulcerative colitis or Crohn's disease, a proctocolectomy also means the creation of an ileostomy. When part of the small intestine is brought through the abdomen to create a stoma, it is called an ileostomy. Therefore, the stool can be passed through the stoma and is received in an ostomy device worn on the outside of the body. The ileostomy can be temporary or permanent. J-pouch surgery is an ileal pouch anal anastomosis, which is done along with proctocolectomy or after proctocolectomy. In this surgery, the last part of the small intestine, called the terminal ileum, is sewn together in the shape of a J and can then hold stool for a period of time, serving like a rectum. Ileoanal anastomosis is done to restore the ability to move stool through the anus. In this surgery, after the rectum and colon are removed, the small intestine is connected directly to the anus. In the total colectomy surgery, entire colon will be removed. Unlike proctocolectomy, the rectum is not removed in this surgery. A total colectomy with partial or complete rectum left in place may be done in certain cases of either Crohn's disease or ulcerative colitis. In a partial colectomy, part of the colon is removed, and it may also sometimes be called a subtotal colectomy. A partial colectomy may be done for certain patients with Crohn's disease, while it is also done to treat colon cancer or diverticulitis. This surgery is never done for the patients with ulcerative colitis, since the disease will often recur in the healthy section of the colon that is left. In hemicolectomy surgery, either the left or the right part of the colon is removed. In a right hemicolectomy, the cecum, ascending colon and a portion of the transverse colon are removed, along with the appendix is attached to the ascending colon. Whereas in a left hemicolectomy, the descending colon and part of the transverse colon are removed. In this surgery, typically the healthy sections of the colon are connected together. Therefore, an ostomy is not required. Now, look at extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on ankle fractures. You have 90 seconds to read questions 37 to 42.
Hello, Doctor. What are the types of ankle fractures?
There are different types of ankle fractures, and treatments vary significantly based on the location and severity of the injury. When a broken ankle occurs, the injury may be to the end of the medial malleolus, called tibia, or to the lateral malleolus, called or both. There are many types of ankle fractures, and let me explain you about certain common types ankle fractures. Lateral malleolus fractures is the ankle fracture that involves only fibula. Most of the lateral malleolus fractures can be treated without surgery if the ankle joint remains stable. A surgery is recommended in case of an unstable joint or the ligaments are damaged. However, the hint for surgical recommendation is when the fibular fracture is within 4 centimeters of the end of the bone. In such case, the fracture can be treated non-surgically if there is no injury on the inner part of the ankle. Medial malleolus fractures involves only tibia. This fracture occurs to the bone on the end of the tibia, which is called the medial malleolus. An isolated medial malleolus fracture is very rare compared with an isolated lateral malleolus fracture. Generally, a displaced medial malleolus fracture is treated with surgery. Bimalleolar ankle fractures involves both fibula and tibia that occur when there is an injury to both the inner and the outer side of the ankle, always resulting in an unstable ankle joint, and surgery is to be recommended for most of the patients with this kind of fracture. Even if the fracture heals without a perfect positioning, the ankle joint alignment will remain disturbed and could result in accelerated arthritis of the ankle. Even after a surgery, ankle cartilage can be damaged at the time of the fracture, resulting in arthritis. Therefore, a proper diagnosis and repair of these fractures is essential to avoid the chance of long-term problems. Although a bimalleolar equivalent fracture involves only fibula, there is also a tear of the ligaments on the inner side of the ankle, resulting in instability of the ankle joint. Therefore, a surgery is essential. Trimalleolar fracture involves both fibula and tibia like a bimalleolar ankle fracture. However, the bone in the back of the tibia called the posterior malleolus is also fractured. At times, if a large fragment of bone is fractured, a surgery is inevitable. Posterior malleolus fracture involves only tibia. This is a rare injury in isolation. Fractures of the posterior malleolus generally occur in association with bimalleolar ankle fractures. In such case, the injury is called a trimalleolar ankle fracture. Mesonerve fracture involves both fibula and tibia, which is a less common injury. However, this injury needs to be diagnosed thoroughly, as there are chances of missing this injury. In this type of fracture, the bone is injured on the inner side of the ankle, called the medial malleolus. The force of this injury passes through the large ligament that connects the two bones of the leg, called the syndesmosis. Since the damage is caused to this supporting ligament, the ankle becomes unstable, and most often a surgery is recommended. This is the end of Part C. You now have 2 minutes to check your answers.